Welcome to another episode of the Visual Pearl series brought to you by the Society for Pediatric Pain Medicine. Each month, we highlight a critical clinical concept with relevance to pediatric pain and regional anesthesia. This June, we bring you an important update on methemoglobinemia, a rare but potentially life-threatening condition with new relevance following a tragic pediatric dental death. Methemoglobinemia represents a critical safety concern in pediatric anesthesia and pain medicine practice. While rare, this potentially life-threatening condition is directly associated with local anesthetics commonly used in our field. Recent case presentations, including the congenital methemoglobinemia scenario featured in this month's Society for Pediatric Pain Medicine Question of the Month, underscore the importance of understanding this condition for safe clinical practice. As pediatric anesthesiologists, we frequently rely on local anesthetics to provide high-quality pain management. Local anesthetic agents are known triggers of methemoglobinemia. This makes understanding drug selection, monitoring, and treatment critical, especially for dental and regional block procedures. Methemoglobinemia is a blood disorder where hemoglobin's iron is oxidized from the ferrous to ferric state. While normal levels are less than 1 to 2%, clinical significance occurs when levels exceed 10 to 15%. The pathophysiology involves dual impairment of oxygen transport. Methemoglobin cannot bind oxygen, reducing oxygen carrying capacity. Additionally, remaining normal hemoglobin undergoes allosteric changes that shift the oxygen dissociation curve leftward, making oxygen release to tissues more difficult. This creates a compound problem: reduced functional hemoglobin combined with impaired oxygen release from remaining hemoglobin. The result is significant tissue hypoxia even when blood oxygen measurements appear relatively normal. Congenital methemoglobinemia is an extremely rare condition, affecting an estimated 1 in 100,000 to 1 in 1 million live births. Mutations cause defects in the enzyme cytochrome B5 reductase. Congenital methemoglobinemia results from deficiency of NADH cytochrome B5 reductase, with type 1 affecting only red blood cells and type 2 affecting all cells, or from autosomal dominant mutations in hemoglobin genes called hemoglobin M variants. It typically presents as persistent cyanosis in infancy. Oxygen saturations remain low, around 85%, and don't improve with oxygen therapy, often leading to misdiagnosis. Co-oximetry and enzyme assays are essential for accurate identification. Acquired methemoglobinemia is caused by exposure to oxidizing agents with increased risk in infants under 6 months, patients with G6PD deficiency, or hereditary reductase deficiency. Clinically, look for central cyanosis that doesn't improve with oxygen, chocolate-colored blood, and discoloration of the lips and mucous membranes. Physiologic stressors like dehydration, acidosis, or sepsis can further increase susceptibility. Symptoms of methemoglobinemia progress with rising levels. Mild cases may present with fatigue or headache. As levels reach 20 to 30%, patients develop shortness of breath, dizziness, and tachycardia. At higher levels, confusion, seizures, and chest pain may occur. Levels above 50% can lead to coma or cardiovascular collapse. Diagnostically, a key clue is a pulse oximetry, reading around 85%, that does not improve with oxygen, paired with a normal PaO2 on arterial blood gas. Definitive diagnosis requires co-oximetry. Multiple agents can oxidize hemoglobin to methemoglobin. In anesthesia and pediatrics, local anesthetics like benzocaine and prilocaine are the most common triggers. Prilocaine is dose-dependent, and benzocaine is not dose-dependent. Dapsone and sulfonamides are culprits in infectious and autoimmune conditions. Household products like naphthalene and industrial chemicals also pose risks. Other medications can also trigger a crisis. Awareness of these agents is critical, especially when treating vulnerable pediatric populations. Topical anesthetics like hurricane spray and MLA cream are common in pediatric and outpatient care. They contain benzocaine, a potent trigger of methemoglobinemia. The risk is high when used repeatedly on broken mucous membranes or in infants. MLA creams and Oroquix combine lidocaine and prilocaine. Awareness of these agents' profiles is key for safe pediatric practice. Standard pulse oximeters use only 2 wavelengths and are not designed to differentiate MED-EHB. This results in false readings, often staying around 85%. Co-oximetry, by using multiple wavelengths, can accurately quantify methemoglobin and should be used for diagnosis. Most hospitals use standard pulse oximetry at the bedside because it's significantly less expensive compared to portable pulse co-oximeters. Co-oximeters also require more maintenance and are typically reserved for high-risk areas like ICUs and operating rooms due to the rarity of conditions like methemoglobinemia and carbon monoxide poisoning. Today's presentation is anchored with a clinical scenario. A 12-year-old patient with congenital methemoglobinemia requires bilateral inferior alveolar nerve blocks for dental extractions. This case, featured in the Society for Pediatric Pain Medicine June 2025 Question of the Month, illustrates critical decision-making principles in local anesthetic selection and monitoring protocols for high-risk pediatric patients. Clinically, patients present with central cyanosis that does not improve with supplemental oxygen. The presence of chocolate-colored blood and a discrepancy between SpO2 and PaO2 levels should raise immediate concern for methemoglobinemia. Co-oximetry should be performed to confirm methemoglobinemia. Monitoring is especially critical in high-risk patients or those exposed to known triggers. When cyanosis is unexplained by other causes, consider methemoglobinemia. If methylene blue is indicated, always consider G6PD status because the standard treatment will not work in these patients. G6PD deficiency presents a treatment paradox. While methylene blue is the standard antidote for methemoglobinemia, it relies on NADPH, something G6PD deficient patients can't produce effectively. Methylene blue may fail and worsen the situation by causing hemolysis. In patients at risk, screen for G6PD deficiency before treatment. Alternatives like IV ascorbic acid or exchange transfusion should be considered. To summarize, always assess G6PD status before using methylene blue. Methylene blue is the first-line treatment. Administered in low doses, it reduces methemoglobin to functional hemoglobin via NADPH-dependent pathways. In G6PD deficiency, alternatives like ascorbic acid or exchange transfusion will be needed. From a regional and pain medicine perspective, careful selection of agents and dosing is key. Avoid known oxidants in high-risk patients and coordinate with dental colleagues for safe practice standards. Prolonged monitoring may be warranted when risk is elevated. Here is an infographic summary. Oxidative stress arises when reactive oxygen species exceed the body's antioxidant defenses. Red blood cells are especially vulnerable, lacking nuclei and mitochondria, and are continually exposed to oxidative agents. Triggers of oxidative stress include infections, oxidizing drugs like sulfonamides, dapsone, and benzocaine, and even certain foods such as fava beans. The enzyme G6PD plays a critical role in producing NADPH, which protects red blood cells from this stress. In G6PD deficiency, inadequate NADPH leads to hemoglobin oxidation, membrane damage, and hemolysis. This oxidative process can convert hemoglobin into methemoglobin, which cannot carry oxygen effectively. Although methylene blue is the standard treatment for acquired methemoglobinemia, it is contraindicated in G6PD deficiency due to its dependence on NADPH for activation, potentially worsening both methemoglobinemia and hemolysis. Importantly, congenital methemoglobinemia is a separate inherited condition unrelated to G6PD. It results from deficiencies in cytochrome B5 reductase, or the presence of hemoglobin M variants, leading to persistent methemoglobin that may or may not respond to methylene blue depending on the subtype. Understanding these distinctions is crucial to safe and effective treatment.
Thank you for joining us for this month's Visual Pearl from the Society for Pediatric Pain Medicine in collaboration with Open Anesthesia. To explore more educational content, visit www.pedspainmedicine.org and www.openanesthesia.org. This episode was created by Dr. Carol Lynn with editorial contributions by Drs. Rita Agarwal, Andrew Din, and Rachel Pedrera. We hope this case-based review enhances your clinical awareness and supports safer care for our pediatric patients. Stay curious, stay informed, and we'll see you next time.